Hello, this is Dr. Anju Singh recording for Anatomy and Physiology from the Lab Manual by Allen and Harper, 6th edition. We will be covering exercise 18 today, the spinal nerves. All right, the spinal nerves, they send information from peripheral sensory receptors to the spinal cord and from the spinal cord to the effectors, which could be muscles or glands. There are 31 pairs of spinal nerves emerging from each side of the spinal cord through the intervertebral foramen between the vertebrae. And they are named after the vertebral region or the level from which they emerge. Now, spinal nerves connect to the spinal cord via the posterior or the dorsal root and the anterior or the ventral root. And these are mixed nerves. That means they have both sensory and motor axons. At this point, I need you to be very careful when you listen to these words. In exercise 17, we talked about the anterior and posterior root. We said the posterior or the dorsal root carries your, is the sensory root. And the anterior or the ventral root is your motor root, okay? And therefore the spinal nerves are mixed nerve because they have both sensory and motor axons. In this chapter, we will be talking about anterior and posterior rami. Do not mix up rami with roots. Roots can be pure sensory or pure motor. Rami are not. And that's going to be one major distinction between exercise 17 and exercise 18. All right. So talking about the structure of a spinal nerve. So here we have a cross-section, a model of a cross-section through a spinal nerve. As you can see, the spinal nerve itself is covered by a connective tissue called the epineurium. If you recall from AP1, you saw a very similar, almost parallel figure of a muscle fiber. So there are a lot of parallels in the structure between a muscle and a nerve. So the spinal nerve is covered by connective tissue known as the epineurium. It is made up of fascicles that are bundles of nerve fibers. Each fascicle is lined by a perineurium. And within this bundle, within the fascicle, you have individual axons. Some of them are myelinated, some of them may be non-myelinated. Remember, some of them are sensory, some of them are motor. Motor ones are usually more myelinated, and sensory ones may be less myelinated. All right, so your fascicle has these axons. Some of them are myelinated, some of them may be unmyelinated, and each nerve fiber is then encapsulated by a connective tissue known as the endoneurium. So you have an axon. The axon may have a myelin sheath around it. In this figure, it does, but there could be other axons that don't have myelination. They have a connective tissue known as the endoneurium around them. Many such axons surrounded by endoneurium are bundled together to form a fascicle, and the fascicle is surrounded by a connective tissue known as the perineurium, and then many fascicles together are bundled together and covered by an epineurium to make up the spinal nerve. All right, so that is your structure of a spinal nerve. Here is a photomicrograph of a transverse section through a fascicle. So this is just one fascicle. So what you saw in the previous diagram, that one little fascicle, that's what's been dissected and stained and we're seeing under the microscope. This is not the entire spinal nerve. It's just one fascicle off the spinal nerve. So the dark purple dots that we see here, let me try and use red, I guess. Okay. So this purple dot in the center, these are your axons. The white area around them, that's the myelin sheath. And then the purple line, so this little one, that circle, that's the axon. This white area around it is the myelin sheath. And then the purple line surrounding that, that is the endoneurium. And all of these little axons surrounded by the endoneurium are surrounded by the perineurium, which is this big purple line layer over here. That's the perineurium. And this is just one fascicle. All right, and many fascicles put together make up a spinal nerve, and they are covered by the epineurium. Now, the important thing here I need you to keep in mind is learning to identify the difference between the anterior-posterior roots that we saw in the previous chapter versus the anterior-posterior rami. So when a spinal nerve, spinal nerve branch, nerves branch lateral to the intervertebral foramen, all right? So this is outside the intervertebral foramen where the spinal nerve has its branches. It has a posterior ramus. This one coming out here is the posterior ramus. This posterior ramus innervates the muscles of the back, all right? Now, rami can contain both sensory and motor fibers. So these are mixed nerves, okay? Your posterior root was here. See, this is your posterior rootlets coming into the spinal cord, and this is your anterior root. So make sure you know the difference between anterior root and anterior ramus, and posterior root and posterior ramus. Don't mix the two up. This is a posterior root is sensory, anterior root is motor. Right motor here, because posterior ramus is mixed. These are both mixed, okay? The posterior root goes back and innervates the muscles of the back, and the anterior root, and we'll talk more about the anterior root in a bit, and then you have these two little things coming out in the front. They are known as the rami communicans, and they communicate with the sympathetic ganglion here. Remember we talked about in the beginning of the nervous system, I told you we have like 100 billion neurons and 100 trillion connections, because everything's connected to everything. And that's why at almost every level you will see connections between neurons, because if you just think about it, when you're sitting there and you hear a noise, your sensory receptors in your ear pick up that noise, your brain receives that noise, and as a consequence of that, you turn your head to look where the noise is coming from. So all the muscles in your neck receive the motor impulse to turn your head. If you recognize that noise, if your brain processed and recognized that's a noise, let's say of a dog, and you are afraid of a dog, your brain could send motor impulses to the muscles in your leg that make you get up and run. Or it could also, it innervates the sympathetic ganglion. It could trigger the fight, flight, or fright response, all right? So that's why these connections are there. Almost every sensory input is capable of connecting to almost every other motor output in the body. And the sympathetic and parasympathetic innervations like your pulse rate and your blood pressure and your adrenaline secretion and stuff like that. All right, so you have the rami communicants coming out that will synapse with the sympathetic ganglion. And also we have these tiny meningeal nerves coming out. See these little guys? They go back and they innervate the meninges. All right, so branches of the spinal nerve, number 1 is the posterior or the dorsal ramus, 2 is the anterior or the ventral ramus, 3 are the meningeal branch, is the meningeal branch, 4 is the rami communicans. So we have 4 different branches of each spinal nerve at every level. Okay, the posterior ramus curves around to the dorsal surface. It innervates the skin and the deep muscles of the back and the trunk. The anterior ramus supplies the muscles and skin for all the 4 limbs, and we'll get into details of that as we move forward in this chapter. Okay, the meningeal branches serves the vertebrae, the vertebral ligaments, the blood vessels of the spinal cord at that level, and the meninges. And the 2 rami communicants, they connect to the sympathetic ganglion of the autonomic nervous system. Here is another figure giving you a view of the rami coming out from neighboring 2 or 3 different spinal nerves. So right on top here, you have this spinal nerve, and these 2 little guys here, they are your rami communicants that are communicating with this sympathetic ganglion. And you can see this is the ganglionic chain. You see these are all these ganglions at the level of each vertebra, and they're connected to each other, and they connect to the rami communicants with that level, and they connect with each other too, so everything's connected. And then here's your posterior ramus coming out, going around and supplying the muscles of the back and the trunk. And then you have the anterior ramus coming out here, and depending on what level this is, so say if this is a cervical spinal nerve, it is most likely going to be supplying the muscles of the upper limb. If it's a lumbar spinal nerve, it is most likely going to be supplying the muscles of the lower limb. All right, so this is your spinal nerve. This is figure 18.4, again showing all the different spinal nerves. So again, in the previous exercise, we learned there were 31 pairs of spinal nerves. How do we get 31 pairs? Because we have 8 cervical vertebrae, 12 thoracic vertebrae, so that adds up to 20, 5 lumbar and 5 sacral, so that adds up to 30. How do we get 31 spinal nerves? That's because we have a coccygeal nerve, one single coccygeal nerve. It's not a paired nerve, all right? Sorry, it is a paired nerve, but there's only one. We don't have more than one coccygeal nerve, all right? Now, these spinal nerves, as they come out, they will braid with each other and form a network of nerves. That braided network of nerves is known as a plexus. Like in the circulatory system in AP1, you learned about anastomosis, when blood vessels communicate with each other and there's collateral circulation, so that body is not deprived of blood in certain conditions. So most organs in the body have some sort of a collateral circulation. Kind of sort of a parallel. These nerves, that when they come out, they braid with each other and they form a network, and this network is known as a plexus. So we have a plexus at the cervical level known as the cervical plexus. We have a plexus at the upper cervical, from C1 to C5 is the cervical plexus. From C5 to T1 is the brachial plexus. Now T1 to T12, the thoracic spinal nerves do not form plexus, all right? Then L1 to L4, we have the lumbar plexus. L4 to S4 is the sacral plexus, all right? So those are your levels of different plexus. The cervical plexus, as I said, goes from C1 to C5, and the nerves that it forms, let me make sure I covered this, and then we'll go to the next figure to talk about the individual nerves. All right, so we got the cervical plexus, brachial plexus, lumbar plexus, and sacral plexus. We got the coccygeal nerve. These are your sacral nerves, lumbar nerves, thoracic nerves, cervical nerves. All right. So coming to the cervical plexus. Cervical plexus is just from C1 to C5. You have one on both the right and one on the left side. The important paired nerves that come out from there is the phrenic nerve. The phrenic nerve supplies the diaphragm, all right? And this is very, very important because diaphragm controls your breathing. So damage to the phrenic nerve can paralyze the diaphragm, and at rest, diaphragm is the most important muscle responsible for breathing. The also interesting part, so if a person undergoes certain neck surgeries and the cervical plexus can get damaged, the phrenic nerve can get damaged. And the other interesting applied aspect, if you will, is if you clean the inside of your ear with a Q-tip, you will often notice you stimulate a cough reflex. And I would ask you to go try this. Get a Q-tip and try cleaning your external ear canal, okay? And invariably at some point where you touch it, it's going to make you cough. And it happens every single time. That's because the sensation inside your ear is connected and sends motor impulses to your diaphragm through the phrenic nerve, which makes the diaphragm spasm, which is what makes you cough. Just an interesting tidbit. All right, so that was from your cervical plexus. Then coming down to your brachial plexus. Brachial plexus is from C5 to T1. So going over through your manual, you will notice in the manual it says that they ask you to remember something, the phrenic nerve is from C3 to 5. And one way to remember that is cervical nerves 3, 4, and 5 keep the diaphragm alive. So any injury or damage to cervical nerves 3, 4, and 5 can threaten the diaphragm. The other cervical nerves, they mainly supply the scalp, the neck, shoulders, and the chest. All right, moving down to the brachial plexus, that is from C5 to T1. They serve the shoulders and the upper limbs. So most of the nerves that are coming out from there are your axillary nerve, median nerve, musculocutaneous nerve, radial, and ulnar nerve. Now, if you look at this figure, you see most of these nerves are coming out sort of like in your armpit, if you will. And an important clinical application of that is, it's called Saturday night palsy. People who go out and party on Saturday night and drink a lot of alcohol, and they pass out sitting on a chair with their hand thrown over the back of the chair, and they sort of pass out all night on that. Because their hand is resting on that chair and the full weight of their body and the head has been on this arm all night long, that temporarily paralyzes these nerves. So when they wake up on Sunday morning, they can't move that hand. That hand is temporarily paralyzed. And therefore it's called Saturday night palsy. It's a palsy that happens to people over Saturday night, and Sunday morning they run to the ER thinking they're paralyzed, but it is temporary, and after circulation is reestablished and the pressure is released, the nerves sort of tingle back to life and the muscles are able to work normally. But these people can be temporarily paralyzed from that pressure and lack of circulation to these nerves overnight. I would encourage you to read table 18.1. That gives you a slightly more detailed idea of what all each of these nerves supply. So we have the axillary nerve that supplies the deltoid muscle and the teres minor muscle. We have the musculocutaneous nerve that supplies most of the muscles in the anterior part of the arm. We have the median nerve that goes, as the name suggests, to the median aspect down here, and it supplies muscles of the anterior forearm and some of the muscles in the hand. Most of the muscles in the hand are supplied by the ulnar nerve. The radial nerve actually goes posteriorly and supplies the extensors of the forearm. All right. So just spend a little time, go over table 18.1 and make sure you have a good idea of which muscles are supplied by what nerve. So for example, you could get a question in the exam, carpal tunnel syndrome, what nerves are affected in the carpal tunnel syndrome? Or somebody who's had Achilles fracture and broken the lower end of their radius and ulnar and is now not able to move, digits 1, 2, and 3. What nerve is most likely damaged? So you'll need to, I need you to spend a little time and think about those answers and be able to identify which nerve is damaged when these digits are not able to move. All right. Coming to the nerves of the lower limb, the lumbar plexus is formed by the anterior rami from L1 to L4. And it supplies the skin and the muscles of the abdominal wall, external genitalia, and some parts of the lower limb. The major nerves that come out from the lumbar plexus are the femoral nerve and the obturator nerve. The femoral nerve supplies the iliacus, the quadriceps femoris, the sartorius, and the pectineus muscle. The obturator nerve supplies the adductor longus, adductor brevis, and parts of the adductor magnus and gracialis. So a question in the exam could be something like, somebody's given birth to a child and post-delivery is not able to, say, adduct their legs. What nerve was injured? I need you to be able to name that nerve, okay? The sacral plexus is formed by the anterior rami of L4 to S4, and this plexus supplies the buttocks, the perineum, and most of the lower limb. The major nerves that come out from there are the pudendal nerve, also known the pudendal nerve, which supplies the muscles of the perineum, the sciatic nerve, and sciatic nerve supplies the biceps femoris, semimembranous, semitendinous, or the hamstrings of the thigh. And sciatic nerve, again, is a very common condition. You've probably heard of sciatica. Patients who have either osteoarthritis or some sort of degenerative condition, or slip disc or whatever, the pressure on the sciatic nerve is a very, very common clinical condition that sends shooting pain down the leg. And so that could be like another question in the exam is, you know, certain shooting pain in certain positions or whatever, which nerve is affected. And you'll have multiple choices. The answer for that would be the sciatic nerve. All right. The other major nerve coming out from the sciatic nerve itself is the tibial and the common fibular nerves. Although the common fibular nerve is also known as the peroneal nerve. So the tibial nerve innervates the gastrocnemius muscle, the soleus muscle, the tibialis posterior, flexor digitorum longus, plantaris, and the flexor hallucis longus. And the common fibular nerve, also known as the peroneal nerve, supplies the fibularis longus muscle, the tibialis anterior, the extensor digitorum longus. So, you know, a question in the exam could be something like somebody's had a stroke, and as a result of the stroke are now experiencing a foot drop. What nerve has been damaged in this condition? So foot drop, that means the foot is dropped. They're not able to dorsiflex their foot. So what nerve is responsible for dorsiflexion? So I need you to look into that and make sure you're able to identify the nerve. Again, I will highly encourage you to do these exercises in the back. You are going to see these questions in the exam. All right, so make sure you go through it. Of course, I won't take it from the book. I'll paraphrase it. But if you know these answers in the back, you are in a good position to answer questions in the exam. This is a figure from the exercise. We've sort of covered this figure already in the chapter. Number 1 is the spinal nerve. Number 2 is the epineurium. Number 3 is the perineurium. 4 is the fascicle. 5 is the endoneurium. And 6 is the axon of a nerve. Again, over here, I haven't labeled these. Again, I would encourage you to label it. This orange thing here that looks like a pumpkin is actually a diaphragm. So 6 is, of course, the phrenic nerve. But make sure, you know, take some time, see if you can label these, because the labeling is not identical to the labeling in the chapter. So they've moved the labels around a little bit. Make sure you're able to trace these nerves and label them appropriately and know which muscles they are supplying. Also know what action the muscles do. So if you ask a question that a person can't dorsiflex something or extend something, you know which muscle innervation is lost, so you know which nerve innervation was lost, okay? And that's the same thing for this. Just make sure you're able to identify all these nerves. And that's the end of this chapter.